In today's case review, we will be talking about caries removal. We want to start by thanking our sponsors, Colteen, Oral Arts Dental Laboratories, and Romero Dental Seminars. Without their continued support, these free case reviews would not be possible. We also want to remind everyone that we are getting closer and closer to Friday, April 26th of this year, where we're going to be holding our next hands-on seminar in the city of Atlanta, Georgia. We will be talking about the imperceptible aesthetic restoration, and we will be dedicating 3 hours of lecture time and 6 hours of a unique, I would say, hands-on experience. So if you want to sign up, we still have some spots remaining. You can visit our webpage, romerodentalseminars.com, or you can click the link below in the description of this video. We also want to remind everyone to sign up or subscribe to our YouTube channel, where we have a collection of all our webinars, over 100 hours of continuing education for free in our YouTube channel. So please don't forget to subscribe. So the objectives that I have for you guys today is going to be these three ones that you see on my screen. How to better access the caries lesion, how to best identify caries affected or infected dentin, and where to remove or to keep caries dentin. So let's start with the first step, how to better access the caries lesion. Now, as you know, once we have our patient numb and ready to, we're ready, we have isolation, and we are ready to access our caries lesion, the first thing that we want to think about is that we want to try to avoid damaging the neighboring tooth. If we have a class 2 situation like the one I'm sharing with you here in this first premolar, we have to make sure that when we access that lesion, we do not impose any damage. We try to prevent any or burst from touching that proximal wall of the neighboring tooth. This is critical because we would like to maintain that proximal wall anatomy intact of the neighboring tooth so that we can obviously restore our proximal wall following the natural contours of teeth. So the first thing that I like to do is I like to initiate my caries access maybe a millimeter to a millimeter and a half away from the marginal ridge or away from from the neighboring tooth proximal wall, as you can see on the photo on the right. So I have initiated my access using maybe a number 2 carbide burr or diamond burr. I'm going through the enamel. In this particular case, there was so much decay underneath this almost intact occlusal surface that once I went through the enamel, the burr literally just dropped into that very soft dentin or underlying dentin. So again, you see me, I'm going maybe half of a millimeter to a millimeter away from that proximal neighboring tooth proximal surface, and I'm literally, staying away from that marginal ridge and just pushing and dropping that burr into that infected dentin. And again, if you look at the right hand side, on the left hand side, you can see that pinkish shadow, that pink brownish shadow underneath that enamel that we normally see in these major lesions when there is a lesion that actually started from that proximal area, normally from lack of flossing for our patients. So this lesion started from that proximal wall and started going into the dentin, allowing that occlusal enamel to literally be intact. But when you see that shadow and you know that there's a lesion there, again, once you isolate, you get the patient numb and you isolate, just drop your burr in and staying away from that marginal ridge, staying away from that proximal surface, that intact proximal surface of the neighboring tooth, so that there is no damage of that area. Now, once I accomplish that access, what I try to do is using the same round burr, or maybe switching to a 245 or a 330 burr, any burr that you're used to using for these type of situations. What I try to do is I try to push my burr towards the proximal wall of the affected tooth, as you are seeing on the left photo of the screen. I'm trying to push my burr towards that affected wall so that I can make that affected wall as thin as possible. You can see that this wall is literally crumbling down every time that I'm pushing with the burr. But what I'm trying to do again is I'm trying to eliminate this wall as low as possible, but as sure as possible, and without touching that neighboring tooth. If for whatever reason I feel that the proximal, the affected proximal wall is not just crumbling down easily, it's not going to break down easily, it's just not going to flick off, then I stop using my handpiece, and what I do is what you see on the right hand side. I use a medium to large size wedge, wooden wedge, and I want this wedge to create a lot of pressure in between these two teeth. So you're going to select the wedge that you feel that is going to be able to go through and through, but that it's also going to create some pressure in the area. And I tell my patient, you're going to feel a lot of pressure in this area. They're not going to feel any pain because they are numb, but they are going to feel a lot of pressure. And by creating that additional pressure, what I'm trying to accomplish is a little bit of orthodontic movement of these two teeth that are very close to each other. And by creating that, I'm actually probably creating maybe a quarter to half of a millimeter space in between the teeth, and that's going to allow me now to push that 245 burr, that 330 burr, or that number 2 round burr, whichever burr you decide to use. I would probably use for this a 245 burr. That's probably what I use for this case. And all I want to do is I want to use that cylindrical long burr just to kind of slowly push buccal and lingual closer to the lingual and the buccal embrasures. Because again, I know that this cavity, this preparation is going to end up being, fairly wide buccal lingually, as you can see on the right hand side. So by creating that additional space, I'm going to be able to push that 245 to make that proximal wall extremely thin, and now I can fracture it either with a curette or a hatchet, just making it very, very thin so that it's easy for me to remove. Sometimes it actually just flies out of the mouth when you're using that 245 burr because it just becomes very, very thin. And this is the first step, the most important aspect of you protecting that neighboring tooth. You can see that I've been able to keep that nice proximal contour on that second premolar because it was not touched by the burr. Now, today you have a lot of wedges that have a portion of a metal band in them that also may be very helpful. I find it to be, I like more just the regular wedges because I find that there's nothing blocking my view. I have tried to use these plastic wedges with this metal inserts that are, again, that are very useful. You can push, you have that metal protecting the neighboring tooth, but for some reason to my eyes, they just block a little bit of the view. So I rather just use a regular wedge. But again, that is another option. If you're using it, just feel free to, and it works for you, I wouldn't change it. But if you're not using any technique and you would like to try one, this is one that again gives you very good view to the operative field at the same time that helps you accomplish that separation between the teeth. And again, just a little bit of a closer photo. You can see one more time that intact proximal wall of the neighboring tooth. But again, the separation, maybe a quarter or half of a millimeter separation that I was able to accomplish between these two teeth. Now I can literally open that box from buccal to lingual, deepen the box as well to get rid of any soft enamel left on that gingival floor. But at the same time, when I'm looking at this cavity, I can see the infected dentin. I can see that brownish, soft type of dentin, leathery type of dentin that has been now exposed, and that I am ready on my next step to initiate removal. And again, one important aspect of having good access is that once you remove that proximal wall, you always end up with these straight walls of enamel. And again, we all know that if we have the opportunity to bevel this enamel, we're going to be able to bond better to this outer enamel. So this outer enamel layer. So beveling this area, even including in that area the gingival floor, makes a big of a difference because it actually creates a 45-degree angle on the enamel prisma where you're going to have better access to the etching and better access to the bonding of that area. So the only way that you're going to be able to bevel these walls that I'm actually showing you here with the arrow is by having a good access, is by creating that separation. If you don't do that, your burr is going to nick the neighboring tooth for sure. So now with the wedge in place, you have seen now that I have been able to not only open or widen buccolingually my boxes a little bit more, but I'm also been able now to bevel the enamel on the lingual and the buccal wall of my box, and also on the gingival floor. So again, just beveling that using a very fine diamond burr, keeping that wedge in place while you're beveling allows you to obtain a final preparation that looks a lot like what you're seeing on this photo, which is ideal for bonding and we all know that. And again, you can see the walls that I was able to kind of bevel at a 45-degree approximately, just cutting through that using a thin mosquito medium grit diamond burr, just a very thin mosquito burr that you would have in a kit like a porcelain veneer kit, just to make sure that you can get in those areas. And again, by creating that separation with the burr, with the wedge, protecting the neighboring tooth from any nicking. My step number two would be how to best identify the caries affected or infected dentin. And again, this is very, very important because it has a lot to do with the bond strength that you will be able to accomplish. And believe it or not, my tip for this particular step is going to be the use of the caries detection dye. There is no better way of removing caries than knowing and being able to visualize and see where the caries is located and where you have to be more efficient at the time of caries removal. And there's nothing that's going to help you more than caries detection dye. Not because I'm telling you to do it, but this has been shown in research. And here is a paper published by Anderson in 1985. So it's not a new paper, but what we found out when you read this paper is that almost 60% of the times caries was left at the area of the DEJ, a very critical area where we want to make sure that we have nice and clean dentin, but it was left behind 60% of the times by dentists. In this particular case, this study was actually done at the dental school in Michigan, and it was done having third and fourth year dental students in the clinic with real patients. And the way that the study was conducted, they had 100 teeth or 100 cavities that were prepared by the third and fourth year dental students, and they were only assessing caries removal using the Explorer and the or the spoon excavator, just like it is normally taught in dental school and still being taught in dental school this way. And what happened later was that these 100 cavities prepared by these dental students was then assessed by was then they applied the caries detection dye after the students had said and the faculty had corroborated that there was no caries left behind. So once they did that, they went ahead. The third investigator went ahead and applied the caries detection dye, and to their surprise, 60% of the times, caries was left behind at the level of the DEJ. And this is critical because it becomes even more critical today when we're doing adhesive dentistry, and we know that we need to have a very nice and clean peripheral seal zone, which is nonetheless 1 to 2 millimeters of the dentin away from that DEJ. So 2 millimeters within that DEJ, we want to make sure that we have nice and clean enamel so that we can call that the peripheral seal zone, and that we know that we can accomplish the highest bond strength to seal our preparations in that peripheral seal zone. So this is why this becomes so important. So what are the things that we are able to identify once we use caries detection dye? Well, we're going to be able to identify three different areas of decay. The first one being the enamel decalcification, and I'm going to show you these three areas on a photo. The second one being the dentin demineralization, but a third one, which is also important, is the collagen denaturalization, which means, and we all know, that there's two different layers of caries dentin. The outer layer of caries dentin and the inner layer of caries dentin. An outer layer of caries dentin that is much more demineralized, that is much more softer, that has denaturalized collagen fibers, and the inner caries layer, that it has less bacteria, has less demineralization, and it's obviously it's deeper, it's closer to the pulp. So we have to make sure that based on the age of our patients and the size of the pulp chamber and the depth of our preparation, we got to make sure that we are very careful when dealing with that inner caries dentin, because that inner caries dentin, it's closer to the pulp, and we have greater risk of pulp exposure, and we want to try to keep our teeth vital. We want to try to keep our teeth with no pulp exposures. So in order for us to do that, that is again the beauty of using a caries detection dye, because this caries detection dye is going to help us identify all of these layers. And this is what you're going to see on the next photo. Again, we spoke about the enamel decalcification, and you can see that even though once I completed my initial preparation, it seemed like the enamel was clean. But I go ahead, I'm sorry, let me go back once. Once I go ahead and I use my caries detection dye, you can see that there is still enamel decalcification present that is now stained by my caries detection dye. And this is after applying the caries detection dye, leaving it in contact with the tooth at least for 10 seconds, and then rinsing and drying. This is what you see. So I'm seeing now, okay, there's some more caries left on that enamel, which is critical. I don't want to have caries on my enamel. I want to make sure that everything is nice and clean. But also, there is those 1 to 2 millimeters of dentin beyond the DEJ, beyond the junction of that enamel and the dentin, that is also stained red with my caries detection dye. What does that mean? Red staining means that this is denaturalized collagen, and that's what helps me separate or identify the outer caries dentin from the inner caries dentin. The inner caries dentin is going to stain a little bit more pink instead of red. So you remove the red and you want to have some pink left behind if you are very deep or close to the pulp. If your patient is a young patient, you know that you're going to have a larger pulp chamber. You know that if you see pink, you want to stop, because again, you do not want to get into the pulp. You want to try to prevent exposing any pulp horn or the pulp chamber. So what we're seeing right now, you're seeing the enamel that has been stained. You see a lot of red staining, which means that there's denaturalized collagen in my entire preparation. You can see the DEJ very stained. So that's what I'm going to now start removing. I'm going to start removing that. And that's going to be my third tip, or my third step, which is where do I remove and where do I decide to keep caries? So we know how to separate the teeth. We know how to identify these layers. Now, how do I remove them? And in summary, I can tell you that you want to remove 100% of your enamel decalcification. So you always want to have a very nice, white, bright enamel, so that you have a very nice and clean enamel. You want to remove at least 60%, and these numbers are not always, it really depends. It's a case to case. I'm just giving you just overall numbers, just for you to give you a numeric value, so that it can create an idea of what your goal should be. You should remove approximately 60% of the dentin, or the demineralized dentin, and you want to have maybe 40% of collagen, denaturalized collagen removal. Again, that's going to be your outer caries dentin, and then you're going to allow, maybe you're going to leave, or you're going to remove maybe that 60% of that inner caries dentin, leaving some of that pink stain within the more deeper caries. And again, this is depending on the depth of your preparation, how close you think you are to the pulp, and you can measure this. There's a way of measuring this: 5 millimeters from the occlusal, 3 millimeters from the adjacent proximal wall of the neighboring tooth. This is going to give you an overall good idea of where that pulp chamber is located, and how, where do you want to be more careful. But you can also do this in older patients just by, again, looking at the color of the dentin. And what you're seeing on the right hand side is me now with I'm seeing a clean enamel. No more caries left behind on that enamel. I'm also seeing 1 to 2 millimeters of that dentin that is beyond my DEJ. So from the DEJ, 1 to 2 millimeters into the actual wall, I'm seeing a very nice and clean dentin. No pink left behind. So everything there should not stain at all, should always be yellow, meaning that you have a nice and clean peripheral dentin, where you're going to create that, what we call that peripheral seal zone. And then what you're seeing on the inside, on the actual wall, is some of that pink left behind. You don't see any red. So we have removed all that denaturalized collagen, but you're seeing some of the pink. So we have removed some of that affected dentin, but we're leaving the deeper layers of that affected dentin, which is what we know, or we call that demineralized dentin area or zone, which is the inner caries dentin, which again is closer to the pulp, and that's what we want to try to prevent, exposing any of that pulp tissue. So again, what you're seeing here is that white layer of enamel, and I'm just going to color all these layers for you so that it's easy for you to identify. Now I have that DEJ. So a beautiful, clean DEJ, which is in between that dent, that enamel, and that 1 to 2 millimeters inner dentin that is nice and clean, which I'm going to call now my peripheral seal zone. And then we're going to have this area that is probably a little bit of pink still staining there. That's again 1 to 2 millimeters past that DEJ. So you still have that peripheral seal zone on the outer, on the outside, that where you're going to get the best bond strength. A little bit of that pinkish area, so maybe a little bit of that dentin left behind, and a little bit darker pink on that axial wall that is a lot more easier for you to see, that you now know is that inner caries dentin that I'm going to stay away from at this point. This is a younger patient. He's in his early 30s, large pulp chamber, and again, I don't want to get closer because I know that I'm at least right now, 4 5 millimeters in depth. I'm very close to that, past that, or close to that 3 millimeter mark from the neighboring tooth. I want to be careful in that area so that I don't expose anything and keep this tooth vital, which is always going to be my goal. Can you bond on top of, if you expose a pulp, a horn, and is there any way that you can control this area and still bond on that, on top of that exposure? There is. This is not the reason why we're talking that. We're not talking about that today, but there's a way, and you can figure out and find it in research. There's a lot of publications on that regards, but this is just a sequence just to show you, how many times did I stain this tooth in order for me to go from that very red stain, all the DEJ, some caries on the enamel and caries on the actual wall, all the way to that nice and clean enamel, good access with beveled enamels on the proximal walls, buccal and lingual box walls of my box, and the gingival floor, clean and nice DEJ, and then again a little bit of that pink and a little bit of a darker pink axial wall. When you think about it, you have all these substrates. You have the enamel, you have the clean DEJ, 2 millimeters within the DEJ. You have a little bit of pink and a little bit of a darker pink left on the axial wall. If you think about it, all these walls, all these different substrates, different, different levels of mineralization of these substrates are definitely going to give you different, or what has been published in the literature as the hierarchy of bondability. And you can hear, Dr. Aleman, Dr. David Aleman, and Dr. Davy Aleman in many of their webinars, and I would highly recommend that you listen to them in their YouTube channel. They talk about this, and they've reviewed a lot of the literature behind this concept. And this is literally what I'm sharing with you now. This is literally what I've learned from them specifically on how to obtain a really good caries removal endpoint, so that my bondability to the substrate, to the dentin specifically, is improved through this technique. So again, just a sequence of photos, 2 to 3 times applying that caries detection dye into I get to what it has been called, or we know today, as a very clean DEJ, as a very good air substrate to bond to, having these different bond strength to these different layers, but most importantly, keeping the highest bond strength to that layer nearest to the enamel, which is that clean peripheral seal zone. And again, just a before and after side-to-side photo where you can see my completed preparation, and that's my tip number one, using that wedge, separating the teeth so that you can, create that ideal box without nicking the neighboring tooth. My second tip was using the caries detection dye so that you can identify all these different layers. And my third tip, where can you leave caries if at all needed because of the depth of your preparation. And in this particular case, that's what you're seeing on that final photo, using these 3 different tips or steps that I've shared with you to get from point A finally to point B. And the idea of the point B, again, is to have that peripheral seal zone caries free, meaning that you have that dentin, that very nice and clean dentin, 2 millimeters within, 1 to 2 millimeters within that the DEJ, and just leaving caries in the deeper areas and allowing some, if at all possible, eliminating all that denaturalized collagen and just leaving some affected dentin there that would again stain pink, as you are seeing in this photo. Now, one more tip that I want to share with you: when I have smaller preparations, if for whatever reason, though you're not able to achieve good separation with your wedge, another thing that I like to do is that once I remove that proximal wall, you can see on the left hand side, I've placed a wedge as a, I create as much pressure as possible. I go ahead and make that wall very, very thin. But if I'm afraid that I'm going to nick that neighboring tooth for whatever reason, maybe the cavity is very small, the preparation is small, and I want to try to be conservative, the size of the burr, 245 or a 330 may be too big for this specific preparation, then you can use a lightning strip, which is a metal strip that has diamond. And I normally use the blue, the red, and the yellow. And I go in and I just shave the enamel. These are only they're only they only have the diamond on one side, so the other side is not going to do anything to the neighboring tooth. But by using these lightning strips, you can also remove very conservatively the enamel and create, as you can see, a very nice and clean enamel. And also you can bevel the walls using this same strip, or even using a mosquito burr if you have enough room for it. But this is a really good tip that helps you be as conservative as possible at the time of your preparation. So again, I want to thank you for being part of our webinar today.